All right. So next on the agenda, we would like to welcome Dr. Ankit Mehta, and is going to do the talk on the kidneys today. So let me read his bio. And I don't know if any of you've noticed, but my left eye looks a little weird. I had a procedure done, and it's irritating me, but light is bothering me, but I'm managing. So if I'm making faces and look funny, that's why. Dr. Mehta is fellowship trained and board certified in nephrology and internal medicine. His professional interests include management of patients with genetic kidney diseases, glomerulonephritis, and fluid electrolyte disorders. Dr. Mehta is a committed educator and currently serves as program director for the Department of Internal Medicine at Baylor University Medical Center, part of Baylor Scott and White Health. He is also an associate professor at Texas A&M School of Medicine, Dallas campus, and a professor at Burnett School of Medicine, TCU Fort Worth. TCU, what is that?
Texas Christian University. Texas Christian University.
Texas Christian University. And he attended medical school at Grant Medical College in Mumbai, India. Dr. Mehta's internship and residency in internal medicine took place at Baylor University Medical Center. This was followed by a nephrology fellowship at Baylor, as well as Dr. Mehta. Dr. Mehta is involved in clinical research at Baylor Scott and White Research Institute and Renal Diseases Research Institute. His research interests include Fabry, L-ports, polycystic kidney disease, and various glomerulonephritis. He continues to have a busy clinical practice with Dallas Nephrology Associates. So welcome, Dr. Mehta. It's good to have you with us.
Thank you, Jerry, for the kind introduction. This is also my first time. I know Dr. Carr was mentioning this was his first time at NFDF, and this is my first time as well, and I'm very excited to be here. So my talk is much more prescriptive as opposed to the prior presentations. I have gone a lot more into detail about management rather than disease presentation. And my thought process was mainly because you guys already know what Fabry disease is. You're already here, you've done basic research, so I need to bring in my thoughts on how to manage much more than how to diagnose or how to figure out organ involvement. So just bear with me as we go through that. First of all, from a kidney doctor standpoint, if you go to an average kidney doctor, 99.999% of their patients do not have Fabry disease. So it's the same analogy as the horses and zebras, right? If you've never seen a zebra, you don't look for one, you're never going to see it. So that is probably the biggest reason why kidney doctors are not as quick at diagnosing these patients, because kidney doctors don't really think about Fabry disease as a first diagnosis when a patient comes to them. It's more about diabetes. It's always diabetes or high blood pressure, and we'll talk about that as well. So here are my disclosures. I'm starting with a clinical case. Let's see if you guys can get the answer. Which of the following genetic diseases is most likely to be associated with the clinical presentation of a 35-year-old man presenting with burning pain in hands and feet worsened by physical activity or heat, protein in the urine, and a family history of kidney failure? Are you sure? I heard B. Are you sure? I know we're making fun of this, but if I present this to the residents, internal medicine residents, the answers are going to be all over. If I present this to nephrology fellows, the answers are going to be all over. And the reason is, again, what we were talking about earlier, where We as in all nephrologists don't really think about Fabry disease because we don't see it as much. There's a second part. After years of protein in the urine, the patient's primary care physician refers him to a nephrologist. After years of watching the protein in the urine worsen and kidney disease worsen, the nephrologist recommends a kidney biopsy. And so our patient gets accidentally diagnosed with Fabry disease. You think this is a joke, but this happens quite often, where nobody thought about it, first encounter, second encounter, 10th encounter with the healthcare system, and then finally accidentally they get diagnosed with Fabry disease. So our patient wants to know about treatment options. Which of the following is true? A, there is no specific treatment for Fabry disease. He needs to tell his doctors to focus on treating the pain. B, there is treatment available and it's too late, but it's too late for him because he already has kidney involvement. C, there is treatment, but it has not shown to be any benefit, especially for kidney disease. And D, multiple Fabry-specific treatment options exist, and they have been shown to benefit kidney disease. The best decision is made jointly by the patient and the clinician.
I vote D.
And again, this is one of those no-brainers, but to drive the point home, many patients, when they're diagnosed at first time, they're actually relieved that they got the diagnosis, that their pain's not in their head. But then the next step quickly is doing a Google search, and then they're worried, what does this mean for me? So it's very important to have a conversation directly between your clinician and the patient to talk that there are many options out there that don't help. So this is the agenda. I hope I can get through this in 20, 25 minutes. I'm going to talk about the Fabry-specific treatments, how to pick the Fabry-specific treatments, monitoring of the patients with Fabry disease, conventional supportive therapy, talk about specifically from kidney standpoint, what are the kidney function tests, what is creatinine, what is GFR, and what is protein in the urine or albumin in the urine, why do we care about that so much? What are the sequelae of kidney disease? Dialysis, transplantation, just a brief introduction to both of those. And then lastly, I'm going to talk about management of Fabry kidney disease as a whole. So I think the previous speakers have gone over this quite well, so I'm not going to spend a lot of time on the clinical presentations of Fabry disease. Classic patients, just from a treatment perspective, need to be treated early and aggressively. Heterozygous females need to be treated if we have evidence of organ involvement or symptoms of Fabry disease that have, consistent with evidence of organ involvement. And if there is no symptoms, we as in clinicians need to go looking for evidence of organ involvement with tests and then decide whether that needs treatment or not. The last group in here is a late onset or specific cardiac only variants, and I've heard of a recent kidney only variant as well. So these patients, again, we need to treat depending on what organ's involved, how severe is the organ involvement. On the left side of the slide, you see Fabry-specific treatments, including the investigational treatments, and there's a lot more investigational treatments than I have listed up here. That is one bright spot in Fabry, is there's a lot more industry effort to try to find new novel treatments and gene therapy. But the enzyme replacement therapies in the US, there are only 2 FDA-approved ones, and I'm going to use the brand names because it's a lot easier than the generic names. But Fabrazyme and Elfabrio are the 2 enzyme replacement therapies. The only chaperone therapy currently on the market is Galafold or Migalastat, but the biggest difference is it's an oral medication. So how do you pick which therapy to use? For me, it starts with a mutation. right? If you have a mutation that is amenable, and we have great data showing that this mutation and a chaperone therapy would work for, then that definitely comes into consideration. The next point is, how old is this person? Like Dr. Hopkins was mentioning, a lot of these therapies have not been tested in kids, so that comes into play for sure. Kidney function again, a lot of therapies have not been tested in kidney function below 30%, GFR below 30, or dialysis for sure, and so that comes into play. Patient preference, it's always going to be oral. That's what I thought at least, but I have patients who want the IV medication because they're worried that they're going to forget the oral pill. They'd rather go to an infusion and get their infusions every 2 weeks because they know they'll do that. Unfortunately, it should be only a conversation between the clinician and the patient, but insurance frequently gets in the way, and the cost of medications and insurance frequently dictates what options we have to use. This is my version of monitoring of patients with Fabry disease, and you've seen variants of this earlier today as well. I do some sort of biomarker assessment every 3 to 6 months, GB3, lyso-GB3, and urine GB3 testing. If the patient is on enzyme replacement therapy, I would do antibody titers just routinely every 3 to 6 months, and then some basic blood tests. Now, I want to remind, this is just monitoring when there is no specific symptoms. Every 12 months, EKG and an echocardiogram. Now, if they have specific symptoms, that duration can be changed, but this is just monitoring. A 24-hour Holter or an implantable loop recorder every 2 to 3 years, just for screening. A cardiac MRI every 3 to 5 years, and a brain MRI every 3 to 5 years. Even if the patients have no heart symptoms, no brain symptoms, no kidney symptoms, this is routine monitoring. Though Dr. Hopkins mentioned that, in children, kidneys are not that big a problem, heart are not big a problem, strokes are not that big a problem. Well, in adults, all of those are big problems, so we need to go looking for them. Now, don't let your doctor do the thing on the top right where you're trying to listen to the head. Please, that doesn't work. We talked about the Fabry-specific treatments. Let me quickly go over the supportive treatments. From a kidney disease perspective, I have 2 main goals: to reduce the amount of protein in the urine and to slow down kidney disease progression. Now, if it does progress, then we can talk about dialysis and transplantation, but the first goal is to try to reduce the amount of protein in the urine to slow down chronic kidney disease progression and blood pressure control. Frequently, patients with early onset Fabry disease and early onset kidney involvement, if the blood pressure is uncontrolled, they progress a lot faster. So blood pressure is a big focus in the kidney world. I have some things mentioned about heart failure. I know Dr. Kolarov went over that in quite detail, but there are specific medications for heart failure with preserved ejection fraction, heart failure with reduced ejection fraction that have shown to be of benefit. There is specific therapy for rhythm disorders for patients with Fabry disease. From a pain management standpoint, we need to think about chronic pain management long-term, as well as management of these pain exacerbations, right? Like suddenly lancinating, shooting pain, or episodes of pain for 2 or 3 days, and then that gets better. So you need to consider both strategies. Stroke prevention, from my standpoint, if I have a patient with a classic male presentation, they should be on stroke prophylaxis with an aspirin or Plavix. All other patients, if I see evidence of strokes on an MRI or history of stroke, then they should be on secondary prophylaxis. But classic males should be on stroke prophylaxis just off the bat, even if they've not had anything. GI disease frequently is quite distressing. There are many treatment options that I listed up there. None of them work very well. All of them we try, rotate through to see what works for which patient. It's just a trial and error. And depression and anxiety management. This is something that's quite underreported. Many of my patients will not come out and say, I'm depressed, but if you actually do a depression screening, it does show up. And it's because of the disease burden that's what's leading to depression. And so as a Fabry physician, we should be better prepared for managing those. So you see that little cartoon over there? My Fabry, that's me in the lounge pulling my hair out, and that's the Fabry patient coming in with the list of the complaints. You guys thought it was the other way around, right? No. But the point there is actually also that we need to pay better attention. We clinicians need to pay better attention to the symptoms of these patients because they have a lot of things going on, and sometimes they don't show up on tests. It is very important to build a Fabry team. No single medical specialty owns Fabry disease. That's good and bad. The bad is that nobody owns the disease, so the patients don't get diagnosed. Nobody takes the lead in treatment. The good is you have many different specialties that are involved, and if you actually build a good team of a Fabry cardiologist, a Fabry nephrologist, a geneticist, a neurologist, a pain specialist, then your patients can get really good care. Shifting gears to the kidney. On the left is a cross-section of a normal kidney, and in the middle is a diseased kidney. So a couple of things I want to point out. You see the outer edge of the normal kidney, which is labeled as cortex. That's where most of the filtering function of the kidney happens. If you look at the diseased kidney, that outer edge is gone. When we're doing a kidney biopsy, that's what we're trying to biopsy, is the outer edge. Now look at the diseased kidney. If I try to biopsy that outer edge on the diseased kidney, I'm going to hit the blood vessel. That's going to be bad. There'll be a lot of bleeding. So the point I'm trying to make here is kidney disease, as it progresses, if it's really advanced, there's almost no point in biopsying because the risks are too high. And you may not even see anything. All you'll see is just scarring. That is another reason Fabry disease gets missed, because kidney doctors sometimes see the patients when the kidney disease are quite advanced already. On the right side, there's a pie chart that tells you of the common causes of chronic kidney disease in the US. And the top two causes are diabetes and high blood pressure. And that is why if you go to a kidney doctor for the first time, they'll ask you, how is your blood pressure? How long have you been diabetic? And what are we doing to control those things? Because those are the commonest causes of chronic kidney disease. If I am seeing a patient who is well known to have Fabry disease and then coming to see me because they have kidney disease or some flag on the kidneys, the first question is always, it should be, is my kidney disease from Fabry? I think a lot of people assume that if you have Fabry disease and kidney disease, the kidney disease is from Fabry. I think that assumption is wrong many times. I think Dr. Hopkins was also mentioning that if you see a kid with lots of protein in the urine, that doesn't make sense. Fabry should not be doing that. We need to investigate further. So this is the algorithm I work through when I'm answering that question. Look for other causes of chronic kidney disease. Go over their history in detail. Is a pattern fitting Fabry disease, Fabry kidney disease? Look for medications that can cause kidney harm. Screen for diabetes. Look at high blood pressure, get home blood pressure readings, not the in-office ones. Look for protein or albumin in the urine, and I'm going to come back to that one to explain more. Screen for the rare kidney disease. Genetic screening used to be so expensive, and now it's really cheap with next-generation sequencing. Screen for other causes of kidney disease. Consider kidney ultrasound. The ultrasound is a very good way to evaluate what the kidney looks like. And consider kidney biopsy. On the right side is a picture of the kidney biopsy that shows Fabry, classic Fabry disease. There are 3 kidney tests that I want to quickly go over. One is creatinine. Creatinine is normally made in the muscles, and the kidneys pee it out. So if the kidneys don't work very well, creatinine in the blood goes up. So it's a very good marker of kidney function. But it fluctuates based on body mass, because remember, it's made in the muscles. So to try to overcome that, we have this thing called eGFR. eGFR stands for estimated glomerular filtration rate. If you pull up any of your prior labs, recent labs, they will have this eGFR number printed on it. Think of this eGFR as a percentage kidney function. So if your eGFR is 90, that's 90% kidney function. eGFR is 60, that's 60% kidney function. I think it's a good correlation to think of it that way. eGFR is a calculation that's based on 3 things now: creatinine, age, and male or female. Those are the only 3 factors that determine eGFR. There were a lot more factors earlier on, but they've simplified it to just 3 factors. Based on the eGFR, we will put everybody in categories or stages of kidney disease. So these stages of kidney disease are progressive from 1 through 5. Stage 1 is normal eGFR, normal kidney function, so GFR greater than 90%. Stage 2 is 60 to 90%, or early kidney disease. Stage 3 is 30 to 60%. Stage 4 is 15 to 30%, and stage 5 is less than 15%, or needing dialysis or transplant. Shifting gears, albumin or protein in the urine. So the way to think about it is protein is important to the body, and the kidneys normally do a great job of holding on to the protein and not letting it leak into the urine. The biggest protein, or the most abundant protein in blood, is albumin. So if you think of kidneys as a filter and they're leaking protein into the urine or albumin into the urine, that's a flag. To me, that says that something's going on with the kidney. Frequently, albumin in the urine or protein in the urine is an earlier flag than the eGFR change or a creatinine change. So it's a much more sensitive way of picking up kidney damage than looking for changes in kidney function. So you may see your physician order a urine protein creatinine ratio or a urine albumin creatinine ratio, and those are both great. I do not think we should do just a simple urine analysis. That's a dipstick, is what you may have done in your doctor's office. That is not as sensitive. The urine protein creatinine ratio is sent to the lab. Urine albumin creatinine ratio, again, is sent to the lab. You get actual number back. That's much more sensitive. So a common question I get is, are my kidneys going to worsen? Is my kidney disease going to progress? So if I look at this chart. On the left side are the GFR stages. Starting with the top row is GFR that's normal, greater than 90%. Going down all the way to the bottom, GFR less than 15%. On the top are albuminuria, or protein in the urine, or albumin in the urine. Albumin in the urine is A1, A2, A3. A1 is normal, A2 is moderately increased, and A3 is severe amount of albumin in the urine. So if I put this as a grid where I put the GFR stage and the albumin on top, you get this heat map. This heat map is very important in helping decide progression. The darker the color, the more likely the kidney disease will progress. The darker the color, the more likely a patient would have chance of heart attack or stroke. So it not only correlates with kidney disease progression, it also correlates with chances of having a heart attack. So this is a good way to think about it. So if you look at the top row, GFR greater than 90, G1 row, and follow along, as albumin in the urine increases, the risk of stroke, heart attack goes up, the risk of chronic kidney disease progression goes up. Are you guys with me? The top row, if you just follow along, right, the color becomes darker. Now, everybody agrees if you go vertically down on the A1, as your kidney disease progresses, the risk of heart attack and stroke goes up. But this is a great way to look at kidney disease and see what are the chances of my kidney disease progressing. If your GFR is greater than 90, and if you have no albumin in the urine, then you're green, you're great. You don't have to worry about kidney disease progressing. By the same corollary, if your GFR is 60 to 90, and you have no albumin in the urine, you're great. If we don't treat chronic kidney disease well, it frequently leads to sequelae and other disorders, and some of them I've listed here. Swelling, edema is a common problem. Blood pressure gets harder to control. Anemia becomes a problem. Phosphate metabolism becomes a problem. Potassium is an issue. Acidosis is an issue. If the kidneys completely progress to the less than 15% or less than 10% is when we talk about options for kidney disease replacement. You guys may have heard of dialysis. There are two kinds, hemodialysis, which is on the left side, and peritoneal dialysis, which is on the right side. Hemodialysis is basically blood that comes out, goes through a machine, cleans, and goes back. And it's typically done 3 times a week at a center. Nowadays, we can do hemodialysis at home as well. From a quality of life perspective, what's better is peritoneal dialysis. Peritoneal dialysis is something that you do at home yourself. There's a small catheter in the stomach. You fill it up with fluid. It sits overnight, and then you drain in the morning, and you're done. Has to be done every night, but quality of life is much better. Even a better option than both of those is a transplant. Kidney transplant patients do a lot better than our dialysis patients. There are 2 kinds of transplants. There's a living transplant or a cadaveric or deceased donor transplant. Living transplants are frequently family members, spouses, children, parents, cousins, friends. The reason living transplant is preferred because patients do a lot better with it than the deceased donor transplant. Also, the wait list, the average wait list for a deceased donor transplant is 5 years. So while you're waiting for the deceased donor transplant, you will be needing dialysis for 5 years. So instead of all of that, most of my patients are managed to get a living transplant even before getting on dialysis. This is my last slide. This is basically putting together Fabry kidney disease management from my standpoint. First is a Fabry-specific therapy. We have data that Fabry-specific therapy actually slows kidney disease progression. Second is exercise. I'm sure most of us don't want to hear that. And weight management. It's a big factor in kidney disease progression. Blood pressure, I've already emphasized blood pressure control, and the blood pressure needs to be normal, not 140. It has to be 130/80 or lower. Salt restriction, stopping medications that cause chronic kidney disease, adjust medications for chronic kidney disease function. And the medications that have been shown to help kidney disease progression are listed here as well. They're ACE inhibitors or angiotensin receptor blockers, and the newest ones are SGLT2 inhibitors and I've just listed some names there as well. If kidney disease progresses in spite of these things, then preemptive transplant before ever needing dialysis is the best option. All right, with that, I'm going to stop. Thank you.
Great, thank you, Dr.
Thank
Mehta.
you.
And we'll, again, after the next presentation, we'll have our panel where you can let loose with your questions.